to just have a casual conversation with you about trust for the longest time because I started this podcast and everybody, it comes up all the time. It's that thing that's always there, that
Mhm.
thread running through everything that nobody really wants to pay attention to.
Mhm.
So I thought, well, let me talk to Toyin about this.
Let's talk about it.
You're the trust lady. But first, introduce yourself. Tell people who you are.
So I'm Toyin Ajayi. I'm a family doc, and I'm the co-founder and the chief health officer at CityBlock Health. We're based in New York. We take care of folks with complex physical, mental health, and social needs across a bunch of different places in the U.S. and really aspire to be trusted and trustworthy source of care and of relationships and accompaniment for people who have lots of reasons to not trust the healthcare system.
So how did you get the idea to found City Block?
Well, so I started, I've always wanted to just take care of people and like help make the world and often people's day to day just a little bit better. I found in healthcare that it's actually really hard to do that as a practicing doctor in most traditional healthcare systems, because I was working as a primary care doc in a community health center, and then as a hospitalist, where I took care of people who had to get admitted to the hospital for things like pneumonia or heart failure or having a heart attack or a stroke. And often I would see them for like 2, 3, 4 days, often at the very worst moments in their lives, right? When you're sick and in the hospital and afraid and vulnerable. And I really wanted to be able to do more to help make sure they never had to go through that again. And I really wanted to understand all the factors that had driven them to be there in the first place. And what I noticed was that more often than not, it was my patients who had fewer means economically, people who were struggling for just day-to-day existence, my patients of color who often had the worst outcomes and often had the fewest resources in the community to help prevent them from coming to the hospital or help take care of them when they got sent home, so that they wouldn't have to come back. And I realized that it was because our healthcare system is pretty broken in most ways that we provide health services, particularly in lower income communities. And that means that we really wait until people get sick before we invest healthcare resources to make sure that they have what they need. It means we don't really think about the connection between the mind and the body and the community and how it
Mm,
drives healthcare and health needs. We send you to a cardiologist if you got a heart problem, a kidney specialist if you've got a kidney problem, but we don't really think about how all of that stuff fits together and how we can better just really address people's social needs as well as their physical needs and then their mental health needs. And we don't spend enough time with people. If we see all the statistics and the data, the average doctor's office appointment or your nurse practitioner's appointment's like less than 10 minutes. And most of the time they're spending on the computer and not really talking or listening to you. And so
mhm.
how could we possibly get to the bottom of what's really happening for people if we're not even spending the time? And then you sort of top it all off, and like our typical system isn't trustworthy, which means like, nobody's following up to make sure you get what you need. You don't always get like robust and clear and consistent information. People don't like always act like they care about where you're coming from or what matters to you. When you think about all the components of a trusted relationship, the system doesn't really have that at scale. And so the idea to found CityBlock was really about trying to think about what would the world look like if healthcare was really different, like if it was tailored to people's needs, if we like didn't make you jump through all these hoops just to get 10 minutes of a doctor's attention. Like what if doctors came to you? What if we texted you or called you even when you weren't in the doctor's office to see how you're doing? What if we had therapists on our team as well as community health partners to like help you navigate your social needs as well as your mental health needs, and just to like be a listening ear sometimes, because sometimes that's all that people need, is to know that somebody cares. And we hypothesized, we really thought that doing all this would actually not only make people healthier and happier, but also it would cost less money for our healthcare system. And what we know is that our healthcare system continues to spend more and more money, but we don't actually see the types of outcomes that we should. We still see that like lower income people, people of color, people with disabilities, people who struggle with mental health needs, they are more likely to come to the hospital with really terrible things that we could have prevented, like strokes and heart attacks. They're more likely to die young. And so we thought we could do better by organizing a system that really like meets people where they're at and tries to like address a holistic set of their needs and not just like one thing at a time. So that was the inspiration.
Yeah. So this notion that we should meet people where they are, you hear that term so much. It's so common that it begins to lose its meaning.
Mm-hmm.
So how are you different? How's CityBlock different when it comes to meeting people where they are?
Yeah, so I think that there's a lot of meanings to that, right? Like there's a very literal, concrete meaning, which I think is important, right? Like, so, you know, for most people, most healthcare providers, no fault of their own, if you need to see your doctor or your nurse practitioner, you got to make an appointment, you got to call in advance, you got to like get childcare if you've got kids, get transportation if you don't live close by, go to the doctor's office, wait in a waiting room in order to get let into the room where you get care, right? Like you physically have to transport your body and like take time off work and bear all of the costs to get to healthcare. So first of all, like, why is that? Like, especially in this day and age, like, it's like, you know, we've got technology. We've also just got like, you know, services that people are used to getting on demand, which means like when you need it, right? And so first of all, like let's physically go to where people are at, which means we'll come to your house if it's more convenient for us to come to your house. We'll connect with you like on text messages. If you'd like to text, we'll do that. I had a patient once who was like, if you just Snapchat me when to take my insulin, then I'll take it. I was like, I don't know yet how to meet you on Snapchat, but like challenge accepted. Like if I can do it, I'll do it, right? Like we'll find you where you're at physically. That means you're on your smartphone, you're at work, but you really just need a quick phone call to check about your medications. It means you're at home and you need somebody to come to your house because the hassle of you getting out the house, you know, with all of the things you got going on is too great. It means, you know, one of the things that always blows my mind is, you know, most primary care and mental health clinics in the community, they don't have after hours access.
I know.
Like, what if you have a problem that's not between 8 and 6? Like
you
most
can
of
go
us
to the
do.
ER.
Like, right? And so it's like, even stuff like that, it's like, we're here for you 24/7. Call, like a human being will answer the phone who cares about you. And like, we'll try to figure out what to do to keep you safe and in your home. So there's that. But then there's the other piece, which is a little bit more like metaphorical, I guess, which is like, we'll meet you where you at, just in terms of what you need from the health system and in terms of all the things that you're bringing with you. And what I mean by that is, you know, traditionally healthcare says, all right, you come to the office, we tell you what's wrong with you, we tell you what to do, and if you do it, you do it, and if you don't, you don't, whatever. But like, I'm going to tell you, right? I'm going to write the prescription. Like, it's not my problem if you don't have money to pay the copay. Not my problem if you don't read English or you don't have your readers and you can't even read the instructions on the pill bottle. It's not my problem if your arthritis in your hand is so bad that you can't open the bottle. It's not my problem if you really don't like the side effects. Like, our job is like, give you the thing and like, so be it. And we know that like some people are not ready to do the things that, even if they want to, they're not ready to do the things that we as healthcare professionals think they ought to do, or they cannot. They want to, but they cannot. So as an example, really easy to tell somebody who's struggling with their high blood pressure, they just need to like exercise and eat better. And they may want to, but like, what if they can't afford to eat like healthy organic food? What if there's like no safe place to go for a walk in their neighborhood in the evenings and they work all day when it's during the daylight? Like, we got to meet you where you're at. And that might mean, actually, you know what? I'm not going to tell you to go exercise by running around your neighborhood. I'm going to work with you and figure out what you can do at home. Like, can we do some squats in the living room? Can we do an exercise video together? Can we work on just substituting like soda, and like, we'll figure out all the rest of the stuff, because actually water is cheaper than soda. That's one thing I know you can do on a budget. Like, we'll meet you where you're at in terms of your stages of change. And if you tell me to go like F off, like you're not ready to talk to somebody about your health, that's cool too. We'll be here for you when you're ready to like really engage. And that piece, that like non-judgmental, non-demanding accompaniment of like really meeting people where they are, like, I will just stand with you if that's all I can do, if that's all you'll let me do, I just want to be beside you while you go through your journey in life. And if you let me, I'm going to try to clear a path that may be a little bit less painful and more comfortable and more aligned with your goals, but only if you let me. And if you don't let me, I'm still going to stand right beside you. And that's cool. And we'll go on the journey together. That's not the way that healthcare is typically treated people and talked to people. It's usually been like our way or the highway. And if you don't do the thing we want you to do, we're going to call you like non-compliant. We're going to say you fell off of the whatever, the treatment path. We're going to like roll our eyes when you come to the doctor's office because your blood pressure is still high. That's not
And
how.
call you non-compliant.
Right.
Very judgmental term. I still hear people saying that.
No,
Yeah.
still. And so like there is something about meeting people, and people know. And when we talk about trust, like, when someone holds you in high regard, when they respect you, when they respect your opinions, when they want the best for you, and when they think you're just like here to take up space and you won't do what they're going to tell you to do anyway.
Yeah, and they have that spidey sense, just like the rest of us, right? I think I told you about my banana story, the lady who was
Yes.
walking by our table and wouldn't say anything, and she brought me a banana and asked me to eat it, and I said, "No, not right now." And she said, "Well, I want to watch you eat it." And her reason for that was she said, "I want to see if you trust us." So that story just
Powerful.
reframed the way I'm thinking about trust. We're trying to be in the community to build trust, but actually thinking about it from our perspective,
Right.
when actually her version of trust was, well, am I an equal? Will
It's
you treat me with dignity and respect,
really
just like
powerful.
your colleague? So
It's really powerful.
what's your impression of that story? I know I told you that story before,
You knew
but
that story just like gave me goosebumps. There's so many things that come to that for me. So like there's some research, it's pretty limited, but there's some research that shows that psychiatrists and therapists who believe in their patients' ability to get better, their patients do better,
Mhm.
right?
Yeah.
So like that's like deep where you take it like, wait a second, like if I believe in that you like want to be better, will get better, you actually do better. Like I invest in the relationship differently. If I trust that you understand your body and your health, me as your doctor, I'm more likely to listen to you. I'm more likely to like go the extra mile to make sure you really understand what's going on. I'm more likely to like take your experience and incorporate it into the recommendations I make for you. And so the bi-directional nature of trust, I think, is really deep. Like it really did, like it was a frame shift for me, and it helped me put those pieces together, which is like, not only do we have to work on building trustworthy systems and work on being worthy of the trust of our patients and our members that we serve, we also
Mhm.
have to trust them. And like part of that is like also, it's so easy. We'll talk about the vaccine as an example, which I know you've been doing so much work around this, right? Like there's a lot of like, oh, these people don't want to take the vaccine. They don't have trust in it. They don't believe in it, blah, blah, blah. And the perspective comes from like, oh, we got to show them this is right and this is wrong. And it's like, well, what if you trust that every person, in particular, the most marginalized people amongst our community, know how to do what's best and what's right for themselves? What if you
Mhm.
trust them, that they know what's right for themselves? Then your job is not to say, you did this wrong, you're making a bad decision. Your job is to say, let me offer you information. I trust that you can hold it and internalize it. I trust that you will think about all the things that matter to you. And I trust that you will make decisions that are right for you. Because guess what? You're like an autonomous adult, right? If we start thinking about like communities of color who distrust the vaccine as like individual autonomous humans who are trying to survive in a world that has been like very, very, very hard, has been trying to have them not survive.
Mhm.
Let's trust that. Let's trust the resiliency and the wisdom and the power and the creativity and the will to live of those individuals and those communities. And let's think of our job differently, right? As like offering tools that they can use, as opposed to offering like a path that is the right path or the wrong path.
Yeah. How do you think we can teach this in medical school and nursing school and pharmacy school, like throughout the healthcare workforce? Can we teach it?
I think so. I mean, the thing that speaks the most to me is always like people's stories. Like I just, I think that for me anyway, and I think that this is true actually of a lot of clinicians, like there's something so privileging about being witness to people's like deepest, most intimate stories. And like, I mean, in what
Mm.
other context, like what other profession can you be like, did you poop today? What
Yeah.
color was it? It's just like, and it's like, and people will tell you, right? Like what, like that's like the level of like,
And they'll tell you all about it and what they saw
that's
and how it floated and how, yeah.
they'll tell you all about it. And like, so we have such a privilege, and I think we don't like value that privilege and then honor it by telling those stories to others and using those stories to shape our own narrative. Which what I mean by that is like the biggest lessons I've learned in my career as a physician and as a sort of leader in healthcare have come from my patients. And when I just put together all of the stories, their life stories, their experiences, drop to me, the things that I'm privileged to like bear witness to in their lives, and I retell that, all it says to me is like resilience, power, wisdom. Maybe it doesn't look the same as your like Harvard trained MD, PhD classmates, but it is like forged in the like reality of like survival in a way that
Mhm.
many of us who are practicing in healthcare have not had to experience. And those like listening to those stories, like the people behind the clinical like presentation, to me is the way to learn, because it starts with empathy and it starts with like real like appreciation, respect for the human beings that we're caring for. And it's very easy when you're running quickly and you're, you know, getting so specialized in like one organ system to forget that this is a human in front of you that you are so lucky to be in the room with and have access to like some of their deepest and most intimate like physical and emotional realities. Like, wow, like take advantage of that and let that shape you and let that help you learn over time. And I think if we can figure out a way to do that, some programs do a lot of like narrative medicine, storytelling, reflection, debrief, like there's something there. But I think tapping into that more and more is like such a powerful way to teach this.
I wish we could send students to spend a week in the home of patients
I
or send
know.
them into the community so that they could hang out on, certain street corners. I know there are some safety issues around that, but there's got to be a way to get people more proximal, because I think that's what's missing and that's where the trust is built, from proximity.
Totally.
You talk a lot about this notion that we should be measuring trust. And trust is very squishy. So all those things you just talked about, empathy, uh, relatability, it's hard for people to get their head around it when you say these health outcomes are being driven by a lack of trust. Well, what does that mean? Because we want to be able to hang on to a specific metric. Like, it's not objective. Like, I drew your blood and now I can see you're anemic because your blood count is low.
Mm-hmm.
So what are your thoughts about why we don't measure trust and why we don't value it as a true driver of poor health outcomes, especially for the poor and underserved?
Yeah. So on the first piece about why we don't value it, I think it's because our healthcare system is predicated on this like economic structure where we get paid for doling out like doses of healthcare. We don't actually get paid for health most of the time, right? Like, and so that's one of the things that's been really important to us as we've been building CityBlock, is like really making sure that our financial model and the way that we contract is aligned around health outcomes and not just around like, did you do a procedure? Did you do an office visit? Did you, spend a few minutes counseling somebody? Because that doesn't like, it doesn't matter if they trust you. If, again, to your point, like if all you have to do is like project a thing
Mm-hmm.
or instrument something or do a procedure, like it doesn't actually matter. Where I think we are going as we go towards what kind of people are calling, increasingly moving towards this sort of value-based payment structures, is we're going to a place where we realize, and those of us who've been sort of operating in this space for longer have long realized that like your ability to actually influence health outcomes, to your point, is tied to not just an episodic relationship, but like a longitudinal relationship, because the types of interventions and changes that that result in real long-term outcomes for health and for medical spend require lots of touch points. They require not only that the person get the prescription, but that they opened it, that they were able to take it, that it had the desired effect, that they continue to take it over time. Like it's that stuff that only happens on the chassis of trust. So I think that we're increasingly starting to care about it. The
I love
measurement,
that, the chassis of trust. It took a minute for that to register. Yes.
it's like the foundation, right? Like you got to build
Yes,
and only build on
absolutely.
top of it. But then the question about how do we measure it? That one, I'm just like, I'm not a measurement expert, but like we measure far more complicated things in healthcare. We figured out how to measure pain, which guess what? You just ask a person. So we could just ask a person, right? Like, do you trust me? Do you trust the system?
We don't want to know the answer.
Yeah, I think so. But also, like, there was a whole industry around measuring pain and treating pain. And, there was a lot of there was a marketing campaign around that for doctors, if you remember, right? Like
Mhm,
it became the
mhm.
next vital sign. It was like, now you got to treat
Yes.
everybody with opioids. Like there was a whole agenda. Like, what's our agenda for trust that's going to force everybody to put it front and center? And my hope is that it's a benevolent one this time. My hope is that it's that we actually want to see outcomes. It's that we are sick and tired of seeing headlines about disparities in healthcare, because we realize that it's an indictment on us and our society. My hope is that there's a positive impetus to create like real measurement, and it literally ask a person, like it's not that hard. Like we can start there. We can build a whole bunch of other frameworks around it if we want to. We can make it as complicated as we want, but like let's start to seize the momentum, right? Like it's an economic momentum around value-based care, and there's like a moral framework that just says like, how much longer can we as an industry and a profession in healthcare continue to dole out stuff, get paid for it, and not even make people healthier? Like how long until we're actually part of the problem, right? And we have to look at that and ask ourselves what we need to do differently.
You're a lot more optimistic than I am. I think people are
Does
doing
that sound
just
optimistic to
fine.
you?
Yeah, I think on the whole, I think people are doing just fine with the system the way it is. And so, I mean, this vaccine rollout is a great example. We're now who didn't anticipate that we would now be talking about the disparities in access to the vaccine.
I know.
So I think without this kind of intention across the board, across the health system, we will continue to see these kinds of disparities, because addressing it requires us to look at ourselves and to change ourselves, the way we approach patients, the way we think about this, the payment structures. And so right now, as much as people are bemoaning fee for service and paying for things like procedures, I still think we have a long way to go before we really shift to this value-based system. Because first of all, I don't even know that we all agree on what that is or how you actually measure value, because a lot of the value is measured by doing things. How many flu shots did you give? Or how many patients got hemoglobin A1C if they were diabetic? And so how do we shift to measure things the patients care about? I
Mm,
also think there are ways to measure trust, like the no-show rates. I
mhm,
think the no-show rates are all about trust.
mhm,
People not picking up their medications at the pharmacy. Have
mhm.
you had those? You've had people tell you stories about how doctors and pharmaceutical companies are drug dealers working together,
Yep. Yep.
right? That's a
Yep.
trust issue.
Of course it is. Of course it is.
Yeah. So I really am watching eagerly to see how you guys progress in this value-based care world, to see if we could actually scale
Mhm.
what you're doing. Can we scale trust? And if so, how?
It's a great question. I believe that we can. I don't have a how yet. I believe that we can. We're working on it. How's that? I mean, I think that there there is a fundamental piece around like you can build trustworthy systems. Let's start there. That's low hanging fruit, right? Like
Mm,
let's start there. Let's like close the loop. let's do what we say we're going to do. Let's show up for people when we say we're going to do it. Let's not like drop the ball when somebody needs a referral or when somebody needs some follow-up or when somebody's supposed to call a patient back. Like that's some low-hanging fruit. So we can start with the systems. The piece around like, how do we reorient the humans in the healthcare system? Largely, honestly, starting with physicians, right? Like who are used to operating from this almost godlike position of remove and power relative to patients and
Yeah.
create something more akin to like a relationship of equals that would allow for trust to form. Like that's going to take some time, but what part of what we've learned is that you can accelerate that by pulling other people into the health ecosystem, like community health workers, as we do in our model, who
Yeah.
are who don't come with all that institutional baggage and who are ready to just meet people where they are and show up and be human and be real with them. Like that's one way that healthcare can start to reform ourselves and become more scalable in terms of the way that we anchor around trust and trustworthiness. But I also think technology can help too, right? Like some of this, like we just follow through, loop closure, operational barriers to trust. You can automate that stuff if it matters to you, right? Like we report on, we automate appointment reminder notifications because it's like how we get people in so that we get paid. But do we automate like follow-up? Do we automate like, did you actually pick up your meds? Like, did we automate like sending you a check-in to find out if you had a side effect when you started the meds? Like that stuff matters too. And again, it matters to feeling like you have a trustworthy ecosystem, and technology can be helpful there as well.
Yeah, so I feel so lucky to have this time with you. So I want to continue to pick your brain about some of these buzzwords we're throwing around, things that we now believe are foundational to addressing healthcare and reducing disparities. So social determinants of health. It's getting a lot of chatter, a lot of funding, startups focused on social determinants of health. How are we doing?
I mean, we are we are okay. So here's the optimistic part of me. Hallelujah. We're finally recognizing and naming that
Finally.
a person's health is not just about the medicines they take, the doctors they see, the diagnoses they have, that like so much of, where we live, where we commune, our lived environment like drives our health outcomes. So that's great. I'll take that. We'll bank it. Like that's a good thing. I started off on a high note. But when we talk about intervening around these and making change, particularly from healthcare, like we're talking about a very narrow sliver of an opportunity. We're talking about healthcare as a place and a nexus for solving, we're really treating social ills that result from an inequitable social infrastructure, right? And so we're saying, hey, look, if you're struggling with mental health and you're struggling with an addiction and you're also struggling because you don't have any housing, maybe we should do some housing interventions for you, and that will help you not go to the hospital as much. But what we're not saying is like, do we fundamentally as a society believe that every human being has a right to a warm place to sleep every night, where they are safe, with a fridge that has enough food for them? And like, we're not actually saying that. What we're saying is that like, if it bumps up against our healthcare goals, then like maybe we'll treat it or intervene. But like, we have a long way to go before we really wrap our arms around where the opportunity is to create healthier communities.
But why do you think we're investing so much in these social, I will call them SDOH solutions? We're, millions, hundreds of millions of dollars. It might even be in the billions by now. Why are we doing that if it's not really getting to the heart of the matter?
Well, I think we're doing that because it gets to the heart of what healthcare is focused on today, which is that like, we actually there's a meaningful opportunity to save money in healthcare by addressing social determinants, right? Like that. And that's, I don't mean to like negate that. That's important, right? Like if you have a person who goes to the emergency room every Friday and Saturday night because they're hungry and they're cold and they don't have a safe place to sleep, we should put them in a house, and it would be cheaper, like orders of magnitude cheaper, right? Than having them in the emergency room where they're going to get sick if they're not sick already, where we're tying up resources that could otherwise be spent taking care of people who have like real medical needs in the moment. So that's all well and good. That's good. That's why healthcare is focused on that. That's where the dollars are. That's where the opportunity is. And I'm good with that. What I am saying though is that there is a much broader problem around it that we're not addressing, and that if we started to really tackle that from a societal level, we wouldn't have to put the person in housing because they were in the emergency room as an alternative. They would already be housed. We wouldn't be talking about, generations of trauma associated with social challenges and deprivations that we then treat with healthcare dollars. Like we would have solved that already. In all but the hardest of cases. And so I think that there's an opportunity to get even further upstream that we're not doing in healthcare. But you got to start somewhere, I guess. So
Yeah, I guess. And for me, I talk a lot about health literacy. I'm the health literacy lady
yes.
because I think low health literacy combined with lack of trust, like that's the perfect storm for poor health outcomes. And speaking of people using the emergency room, I interviewed a gentleman who, even though he had a healthcare provider, he only used the emergency room for his healthcare. And do you know what the reason? The reason is because he actually couldn't read. He was low literacy, background literacy. And I only figured it out at the end of the interview because I wanted to send him text messages and he kept saying, well, just call me on the phone. And I think people like that are forced to navigate healthcare because they're invisible to us. We're so busy with our paperwork and moving from one thing to the next. People like him get lost in the system. So we need to figure out ways to look out for people like that too, and really address the root cause of the problem. It's not just, let me give you a cab voucher so that you can get to your clinic visit. A lot of people can get to the clinic visit if they really want to go. I had a patient who would take 3 buses to come and see me because he wanted to. Yeah. So the last thing, I'm going to put you on the spot with this one. We're also talking a lot about health equity now. And you alluded to this in one of your previous answers. What is health equity? And do we really want it?
Oh, okay. Well,
I mean the proverbial we as because I think a lot of people feel when we say health equity, we mean everybody, no matter who you are, gets the same thing all the time, everywhere. And so, yeah, I think there's a lot of lip service. So I would love to hear your take on it. What is it?
We've been getting this wrong for a long time, right? Like that's kind of the ethos in which I trained. I'm sure you train the same way. We don't see insurance status. We certainly don't see race. Like we just do like evidence-based medicine for everyone. Boom. And that we know does not produce equity in outcomes because people are starting from very different places based on what we have offered to them or not in their past, based on the ways that our society has treated or mistreated, marginalized or privileged them. We're not starting from the same place. So it's like saying, we're going to eradicate poverty by giving everybody a $200 check. It's like, no, that's not how this works. Like some people need all the money and some people don't need another check. And we need to start to understand like what it looks like to create outcomes that show that we care about everybody, not just about the average person, not just about the most privileged amongst us. That's what equity is, right? It's not like, what did you do to get there? It's like, did you get there? And what we know now is that we see these like massive, massive disparities in outcomes based on race, ethnicity as one parameter, based on whether or not you have a mental illness or not, whether you struggle with an addiction or not, whether you live in an urban or a rural setting, whether your parents were wealthy and educated, whether you were a first generation American for whom English is not their first language. Like there's so many different dimensions across which, based on things that are just inherent to you and the way that society has treated you and people like you, if we give you $200, you're much less likely to be out of poverty than if you were starting from somewhere else in the equivalent of that. And therefore, if we really like care about this, which I believe we do, because I think we're increasingly finding, and I think starting to believe that that inequity hurts all of us, not just the people who are marginalized and suffering, although they suffer the most for sure. An inequitable health system ultimately will impact all of us because
How? I think that's the piece people aren't connecting with, because, people say, well, we're only as strong as sort of the least, the least of us, right? Do people really believe that? So how does it
I mean,
impact people?
but for the luck, if you're a believer in some other higher power, but for their grace, I don't know. It could be any of us. We have a system that basically says, you are one health catastrophe away from bankruptcy for most people in this country. You could lose that job, you could lose that insurance, you have no health care. Then you become one of them, right? Now, obviously, like people who are not from, a racial ethnic background like mine cannot ever experience what it looks like and feels like to be a Black woman in America. I'm not saying that. I'm not saying that like it could all just be everyone mixed up together. But what I am saying is that if you watch the way we treat the poor and the marginalized and the people who are voiceless in this society, it could be you one day for sure, because there's nobody out there looking out for anybody in the way that our system is constructed today. And so I offer that as a really sobering reflection, right? Like we are only as strong and as safe as the weakest and most marginalized amongst us. That is true. It is also a moral indictment on us as we continue to watch the sort of the gap grow between those who have and those who are struggling. We're going to be forced to ask some fundamental questions about what it says about us as a society. I think that's important. And so, this push currently, I think, is like a really powerful push to say, okay, let's ask not only how's the average person doing in this population, or how's the most privileged person doing in this population, but like, what's the spread? What's the gap between those who are doing great and those who are struggling? And how's the person who's really struggling the most doing? And what is your plan to close that gap? And that's what equity looks like. And that's what our healthcare system, I believe, is starting to at least think about and talk about. We haven't solved it by any means, but we're starting to talk about it.
Yeah, and I hope we find ways to have that message really pierce people's psyche and hearts, because I think that's what it's going to take, a lot of compassion and empathy to get there. So before we go, you are great at telling stories. So I want you to tell us a story. You've been at this a long time, even before you founded CityBlock or co-founded CityBlock. And I remember you telling this story about Charlene and, the lady who had, people weren't listening to her and considering her circumstances. So I know you got this problem a long time ago. But we all learn from our experiences. And so here you are, what is it, 2 or 3 years in at CityBlock?
Yeah.
I would love to hear a story that really touched you and taught you something beyond what you already knew coming into CityBlock as a co-founder.
Ooh, gosh, you really did put me on the spot here on this one.
I could have given you a heads up on that.
You could have. That would have been so nice. Wouldn't that have been lovely, Lisa?
I just thought of it as I was listening.
It's a really good question. I'm trying to like rack my brain, and I want to.
Well, and for me, that's like the banana, right? The banana story. So,
I'll tell you a story from before CityBlock, but that really resonated for me, and I continue to draw lessons here. I had a patient who I was taking care of. I was her primary care doctor. We still are a little bit in touch. And she gave me permission to share this story because it was was like poetry to me. She has a really long history of having mental health challenges, and will tell you stories of kind of all of the psychiatric units she cycled through when she was younger, and the ways that she kind of learned to game the system and really advocate for herself, even despite the fact that as a Black woman with a mental health diagnosis, a serious mental health diagnosis, people always thought she didn't know what was going on. And she also had a couple physical problems. She had diabetes, it's really bad. She had a seizure disorder, it was pretty bad, and would often go to the hospital with a seizure, with a bad, high blood sugar from her diabetes because she wasn't taking her meds. And we were pretty early in our relationship, and we decided to go for a walk. It was like a beautiful day, and we went for a walk, and we talked and we talked. She told me her whole life story, and I was kind of sad that we were walking because I wanted to be writing this down. Like there was just so many like vivid parts of her history that were so powerful. But there's something about the rhythmic nature of moving outside that I think just like opens up, a conversation. And I was also vulnerable with her. I told her about my childhood, and we shared experiences and really got to know each other as people. And she said, "Hey, Dr. T, I need you to know something." She said, "I'm not non-compliant, I'm defiant." And I was like, okay, no, I stopped in my tracks. I was like, say that one more time. And what I learned was a couple things. One is, she'd heard all the things that people said about her in the healthcare system. She'd heard them say, oh, she's a 60-something-year-old lady, non-compliant, comes in here with seizure, blah, blah, blah. She'd heard all that stuff. Whether or not people said it to her face, she knew exactly what people thought of her. And what she wanted me to know is that she was a person with agency, and she was seizing control. And sometimes, and I make this up, this part I made up, I like make it up and I infer it, but I think it's true. Sometimes when you have had no control and no agency for your entire life, you've been told where to go to school, you've been told when you're hospitalized, where to sleep, what to eat, what to do. Like if you are poor and you're a woman of color in this country, and you were born in the 1950s, 1940s, you have not had a lot of control over your life. No. And you exercise your control and your agency however you please. And sometimes that looks like not doing what the doctors want you to do. But that is you saying, I'm in charge of my life. And for me, that was like, because what I learned from that was that trauma and marginalization and oppression sometimes shows up in healthcare in an oppositional way. It sometimes shows up like people aren't doing what they should do for their health and well-being, when actually they're like making choices, or they're just saying, I'm alive and I'm here and I have a say. And that was really powerful for me.
Yeah, that's beautiful. And I got goosebumps hearing that.
She's profound human.
Well, keep thinking about those stories, and I'm sure you're going to think of one. You'll be in the shower, or you'll be exercising or doing something random. You're like, oh, but you can always come back, and we can do it on IG.
I have to figure out how to do that. That sounds hard.
I know. I'm struggling with the social media myself. I do, we do the best we can. So, but thank you so much. I'm so happy to have this time with you. And thank you so much for all you're doing for the community. And I wish you the best of luck. I'll be watching.
Thank you. I know you well, and I appreciate everything you do. You're a real inspiration to me. You know that. I appreciate you.
Thank you. All right. Well, have a good night.
You too. Bye.
All right. Bye.